My name is Corinne Pittman. I'm a fourth-year medical student with Howard University College of Medicine. And the title of my presentation today is Vestibular Schwannoma, Does the Degree of Resection Dictate Tumor Control? For the last decade, emphasis with microsurgical resection of vestibular schwannomas has really shifted towards function preservation over complete tumor removal. And with this shift in mind, the research question became, how does the degree of tumor resection affect tumor growth and long-term outcomes following microsurgical removal of vestibular schwannomas? I'm going to briefly start out with a case. So AC is a 51-year-old woman with a 3-month history of a gradually progressive right-sided hearing loss that was accompanied by tinnitus, fullness, and a sense of disequilibrium. Her history was largely unremarkable, as shown here. She had a history of well-controlled hypertension and obesity, but was otherwise a good surgical candidate. Her audiogram shown here demonstrates a mild to profound right-sided hearing loss with a moderate sensorineural hearing loss in the mid-frequencies around 1,000 hertz, with a return to good hearing around 3,000 hertz, followed by the ski slope decline in hearing at 6,000 hertz. She also had a preserved speech discrimination at 96%, and taken together, these findings contributed to them as major factors behind the surgical approach and treatment that was chosen for her. So this is an axial MRI T1 weighted post-gadolinium contrast image cut through the level of the cerebellum, and it's showing a mass that measures 2.8 centimeters along the temporal axis and 2.1 centimeters along the IAC axis. We can see there's this focal area of hyperintensity that's relatively large, with a few smaller hypointense areas scattered throughout that might be consistent with internal cyst formation. And there's also this mass effect contributing to brainstem compression. So while this mass could be an arachnoid cyst, a meningioma, epidermoid tumor, or even a facial nerve neuroma, given the MRI findings, it's most likely consistent with a vestibular schwannoma. Given her age and the size of the tumor, the patient, surgeon, and team elected to proceed with a microsurgical removal. A retrosigmoidal approach was selected given the goal to preserve her hearing as much as possible. And intraoperatively, the decision was made to move forward with a near total resection because of how adherent the mass was to the facial nerve, and she had good facial nerve function preoperatively as well. She had an uneventful hospital course. Of note, preoperatively, she had normal facial nerve function. Postoperatively, we graded her at a House-Brackman grade 2. That was maintained post-op days 1 through 3, and she was discharged on post-op day 3. I'm now going to briefly touch on an overview of what a vestibular schwannoma is before proceeding with a literature review. So the term acoustic neuroma is actually a misnomer, as this tumor more often arises from vestibular nerves, not the cochlear or acoustic nerves, and it's a derivative of myelin-producing Schwann cells, not neuroglial cells. Its clinical presentation additionally comes from its impact on adjacent structures within the area of the CPA. Typically, the tumor involves the CPA or the IAC. So now to answer our question of the role of degree of resection of vestibular schwannomas, specifically, does it contribute to tumor control and improved facial nerve outcomes? I'm going to discuss 3 papers that will contribute some of the most recent literature on this topic. So this is the most recent multi-center prospective trial that looks at the degree of resection and long-term outcomes. It has 132 patients split between 2 different surgical approaches. You can see the majority of patients received a translabyrinthine approach, while the remaining third, a retrosigmoid approach to microsurgical resection. All of the patients had vestibular schwannomas that were considered large in size, that was 2.5 centimeters or more, and underwent a gross total, near total, or subtotal resection. Radiation treatment was considered postoperatively if a tumor showed any sign of regrowth following a gross total resection, or growth of any tumor remnant in the case of a near or subtotal resection as determined by serial imaging. So the degree of resection was defined differently by each study, and there's actually considerable variability in the literature concerning the definition of near and subtotal resections, and this really makes outcome interpretation and comparison between studies quite challenging. This particular study's definition of degree of resection will vary slightly from the next two papers that I'll discuss. However, all three papers use the same definition of near total resection. The current defines gross total resection as no tumor remnant visible at the conclusion of surgery, near total as any tumor remnant less than 5 millimeters along the temporal bone axis and less than 2 millimeters along the IAC axis, and subtotal resection tumor remnant as shown by volume and surface area. So as this is an ongoing 10-year prospective trial, these are just interim results from patients who underwent at least 1 year of follow-up. The most significant findings I've highlighted here in red. Thus far, about 20% of the cases have had regrowth, and regrowth was found to vary by the type of resection that patients underwent, with similar outcomes you can see between gross and near total resections, but significantly more regrowth for those who underwent a subtotal resection. Another notable finding is the very poor tumor control rates amongst patients who underwent a subtotal resection and subsequent radiation therapy, with a 36% overall failure and an astounding 67% for intensity modulated radiation therapy following a subtotal resection. So one of the different things that we think about in terms of why we proceed with one method of microsurgical resection versus another is the question of the facial nerve outcomes. Based on this research group's findings, there are no difference in facial nerve outcomes when comparing the 3 different degrees of resection, and this was measured at 2 different time points immediately postoperatively and at 1 year post-op. Better immediate facial nerve function postoperatively was found to be associated with a smaller preoperative tumor size and tumor remnant left behind on MRI. However, this finding was not statistically significant when looking at the 1 year follow-up mark. So this study, it's also important to know, is comparing all 3 degrees of resection simultaneously without any form of post-hoc analysis between gross, sub, and near total resection separately as independent entities. So now we've gone through this first article. To summarize, this is the most current prospective trial to look at degree of resection and tumor control rate. Subtotal resection of vestibular schwannoma resulted in higher rates of recurrence and required adjuvant therapy. And finally, this group found a significant difference in tumor regrowth among patients following a subtotal resection compared to near total and gross total resection, with a similar difference in tumor regrowth following a near total resection and gross total resection. So I'll now move to the second article. To narrow in on my original research question, as opposed to looking at the 3 different degrees of resection, Dr. Link's team, shown here at Mayo Clinic, is focusing solely on the difference between subtotal and near total resections in an effort to determine whether there is residual tumor volume that will predict the chances of regrowth in the future. This team defines near total resection the same way as the first article, but lacks those strict values to define subtotal resection as demonstrated by Dr. Jackler's group in the previous article. The main difference of this article is that it's retrospective in nature, and they look at 103 patients who underwent vestibular schwannoma resection over a 14-year period. So looking at this Kaplan-Meier curve of recurrence-free survival, we do see some of the same findings as in the first article, in that there is a difference in recurrence between near and subtotal resections, with patients 13 times more likely to experience a recurrence from a subtotal than a near total resection. And you can also see here that the time interval to recurrence following a near total resection is really just over 3 times longer than that compared to a subtotal resection. So to summarize the second article, the study tells us that with any less than complete tumor resection, the risk of recurrence and time interval to regrowth is largely associated with the initial extent of resection, with significantly lower recurrence rates found with near total as compared to subtotal resection. Additionally, regrowth may occur several years after an incomplete vestibular schwannoma resection, and a pattern of late recurrence after a long period of no growth is really rather specific to a near total resection. So it may have been that there was just not long enough of a follow-up period with this study. So this brings me to my third and final article, in which this study is performed by the same group, but looked over a longer period of 15 to 30 years follow-up. So Article 3 is another retrospective study from the same group at Mayo Clinic, following people over a much longer period of time. Instead of looking at subtotal and near total resection, here they're now looking at gross total resection as it compares to subtotal resection and the long-term risk of recurrence among these degrees of resection. Of note, only 18 of the cases were performed via subtotal resection, and though it wasn't explicitly stated, my thought is that it's due to the time period. Charts reviewed were from the years 1980 through 1999, and this was a time when historically, at least based on literature, it looks like gross total or complete resection was more of a standard. So this Kaplan-Meier plot demonstrates recurrence-free survival by gross total versus subtotal resection. And if you look down here, the total population size at risk and the number of individuals affected by degree of resection is shown in the following years follow-up. So of the 18 who underwent a subtotal resection, by year 5, 7 had already shown recurrence, and by year 15, over half of the patients had experienced a recurrence following a subtotal resection. And you can also notice this much steeper slope decline following a subtotal resection. So here, once again, we're seeing similar findings that subtotal resection has high recurrence rates, whether we're comparing this form of resection to near total or as in this current study to gross total resection. So the summary of these findings are as follows. First, subtotal resection alone should likely not be considered a long-term treatment option, given that this study showed essentially all patients, if followed for a long enough period of time, may ultimately demonstrate a further growth of the tumor remnant. Secondly, long-term tumor surveillance is critical in that a negative scan at 5 years follow-up shouldn't necessarily eradicate the need for further follow-up, but rather could help guide the frequency of future imaging and surveillance. And in short, this study really emphasizes the importance of long-term follow-up when reporting tumor control outcomes for vestibular schwannomas. So to conclude my presentation, I just want to briefly draw back to my original case. So for our patient who underwent a near total resection, this is a pretty typical MRI finding postoperatively. You'll notice the sliver of tissue remaining following the resection as indicated by that yellow arrow. And then on the right, I went over with the pathologist the final pathology findings. And something that was interesting to me was some of the facial nerve, they believe was also resected along with the tumor. And that kind of just demonstrates again how adherent the tumor really was to the facial nerve at the time of resection. So based on current literature and our current understanding, we think that she'll be well served with this approach. We saw good facial nerve outcomes in her postoperatively and are hopeful, knowing that there is evidence to support a relatively low risk of recurrence for several years compared to subtotal resection, which again, along with gross total, might have been more of the standard in the past. So in conclusion, as a clinician, for a young patient with a longer life expectancy, the literature review today seemed to provide evidence that would advocate for a maximum safe resection to preserve that preserves facial nerve function, avoids risk of recurrence, and further risk of damage to facial nerve auditory function in the long run. So as a way forward for future research to address the unknown, it could be interesting to understand the reliability of tumor regrowth as a measure of long-term facial nerve function and hearing outcome, the role of early post-op radiation on long-term tumor control, and the size and or location of remnant tumor that could warrant further post-operative radiation. These are my references. A special thank you to Dr. Kim at Georgetown, who helped me with this presentation, as well as Dr. Hobson and Dr. Johnson, who also spent time helping me with this presentation today. And again, in the interest of time, I'm happy to take any questions now and via email later. Thank you.